I'd like to welcome you all to the Coaching Corner. This is our last one for the year. So it's very exciting to be back in the office and teaching face-to-face, and this will be our last Coaching Corner now until we're skipping January because we're having a break and having a holiday. So we'll be back first Thursday of the month in February. And again, I'd like to just acknowledge the generous sponsorship of Philips in bringing these Coaching Corner sessions to you. So tonight's topic is looking at fracture assessment and management. So, once upon a time, I'm a stenographer at heart, and once upon a time, there were this, you could not scan the bowel. Ultrasound was useless for the bowel. It was no good at the lung. And there are still people who think that. You couldn't see the brain either, and you certainly wouldn't use the ultrasound to look at bony structures. And now we scan the bowel, we scan the lung, we look at the brain and at intracranial pressures and stuff, and we can certainly see bony structures, that's for sure. So it's kind of like, this fairy tale of things that you just can't do. Ultrasound can go pretty much everywhere now. So in diagnosing or managing patients who fractured their wrists, we can use ultrasound for diagnosis, for pain relief, and to look at the reduction and to see if their bones have been realigned. Plain radiographs in most cases are still the gold standard for definitive diagnosis, but there's growing evidence that ultrasound, which provides zero radiation to the patient, that it can be, in many of the cases that I've been looking through, as sensitive and specific as the X-rays. Especially in young kids, we've got growing bones, so they are more sensitive to ionizing radiation, and we want to keep the radiation doses down as much as we can. So being able to use ultrasound for this is really useful. And certainly if you're working in, remote locations where you don't have access to all the fancy imaging equipment or access to an on-call service, being able to pop on an ultrasound to check and see if it's fractured and if it has been aligned correctly can certainly be really, really helpful. We are used to looking at bony structures on ultrasound. We use it as a landmark for many other things. So you'll be familiar with the bony landmark of the vertebra when we're looking at the aorta, for example, and you see the curvy linear anterior surface of the vertebral body there with the shadowing behind. And then in the longitudinal view, we use the spine sign when we're looking to see if there's pleural effusion. So we're used to looking for the vertebrae and for bones, and we recognize their pattern as being that bright white structure that reflects a lot of sound, but doesn't transmit a whole lot of sound. So ultrasound is really, really cool and can, if you didn't already get the idea that that's what I'm on about, the ultrasound is really useful for long bones. It can be good for pediatric skull fractures, and it plays a really important role for sternal fractures and rib fractures. Now, some will suggest that, maybe I don't want to spend all that time looking for rib fractures, but you can actually see some of those tiny rib fractures that can be awfully painful that you might miss on a plain radiograph, but we'll get into that a little bit more in a minute. So we want to have a look here at the scan technique, and I'm going to use the example of a Colles fracture. The technique and principles are the same for other bony examples. So, whether it's a broken arm or a broken femur, the principles of how you conduct the scan and how you perform the scan are very similar. So we start with a linear probe. The structures that we're looking at are quite close to the surface, so we want high frequency so we get good definition of those superficial tissues. The preset should be musculoskeletal or small parts or even a soft tissue preset if that's all you've got on your machine. Now, because of the size of the linear transducer, we can only look at small sections of the bone at a time. So you do need to do a step-by-step process to systematically review the whole of the bony cortex. With nearly all of the extremity bones, Anywhere that the bone is covering other bony facets, you just don't see so well. So it's not the best at looking deep into the joints and things, because we get reflection of the sound at the surface there. And so we do recommend like a 3 sort of view per bone technique. We want to approach it from the front, from behind, and from the side. Obviously, we can't get to that middle side there, but because we only see the bony cortex, and we only see the bony cortex where our ultrasound intersects the bone, we do need to approach it and do a few passes so that we look at all the bone. Now, if you've got a fracture that has broken through the whole thing and there's quite a bit of malalignment, well, then it becomes quite easy. But, you know, for some of these really small ones, like a green stick fracture or something, you do just need to be really quite systematic and look at each of the different surfaces of the bone. Now, when we're looking at fractures, disruptions as small as 1 millimeter can be detected. And it's quite easy to see the discontinuity of the bone. So I think one of the most important things here, you know, their arm will be sore. So we need to be really generous with the gel. And I like the, I'm a bit of a gel snob. I think I've said that before, but I really like the really thick gel that sits and doesn't slip off everywhere. I want to use the gel as like a standoff pad so that I'm not pushing on the tender limb. So, you know, be really generous with the gel and balance your probe on the gel rather than pushing down, because I'm sure your patients will complain about that. So essentially, you know, you can see where the deformity is, and you just want to be really systematic about sliding down in a longitudinal scan plane along that bony cortex. And then, of course, we need to look at the other bone in the ulna in the forearm. You can look at the bone in transverse, and of course you'll get a very different view on it, but you will still see those disruptions. And as with any other structure, it's always good to confirm in 2 planes that something's going on and it's not just an artifact that you're seeing. And then we want to look on that inside surface as well. And again, use a very generous blob of gel so that you can do this without putting too much pressure on the lid. And what we want to do is focus our attention on the continuity of the echogenic cortex of the bone. So when you have a normal bone, it looks like this bright white line. And when we look at that in short axis, you can see this curved structure, and it's still very smooth in its appearances. We need to be careful with our gain settings and stuff. So you want to adjust the gain so that the bony cortex is a bright white. You need shallow depth settings. We want that bony cortex to be in the focal zone of the transducer. And the high impedance difference between the bone and soft tissue causes an almost complete reflection of the acoustic waves at the bony surface. As a result, all we see is the cortex of the bone, because behind that there's no sound transmission and we get shadowing behind it. So the underlying structures are not seen. If we look at this X-ray, you can see that really nice, smooth, bony cortex. We need to make sure we direct the ultrasound beam perpendicular to the bone so that the sound wave hits it and we get the best reflection that we can. You can see here that the bony cortex, again, is that bright white. So we have the subcutaneous tissue here. We have the muscle tissue, and depending on your patient and which bone you're looking at, how much subcutaneous tissue or muscle tissue you can see. You have the bony cortex here, and all of this behind that bony cortex is reverberation artifact. So imagine if this is someone's upper thigh and you're approaching from the back and they have generous hips. You may even need to use a curved probe to get enough penetration so that you can see the bone. It really does depend on how much tissue there is between you and the bony surface. So you need to be mindful of your depth settings and just how far you need to get into the body to get a reflection of the bone. So what are some of the things we can't see? Well, we can't see any bones that are covered by other bones. So joint facets are really not very well visualized at all. Small bones are very difficult to examine like the carpal bones and the tarsal bones. I think the most difficult thing about the carpal and tarsal bones is just there are so many. I don't know. I need to look at the anatomy textbook and just sit there and really sequentially figure it out. But it can be really quite confusing because, you know, unless you work from the same landmark and work your way along, you lose your way along the way. And by the time you've taken your eye off the picture to look at the textbook to go, well, which bone am I up to? Unless you have amazing memory of anatomy, you know, you lose your place. And they're also very small. And so being able to visualize fractures is not so easy. Ultrasound's not great for the vertebral bodies. I mean, we do see them. I illustrated that earlier, but it's more as a landmark for other structures. We don't use ultrasound to figure out whether the spine is fractured. If you're looking anteriorly, depending on your patient, how much tissue there is between the probe and the vertebral body, but you do only see the cortex. If we look from the back, the spinous processes will obstruct the sound, so you don't see terribly far in. And I was talking about those small bones before. The carpal bones and the tarsal bones are just really confusing. So the most important thing here, we can see on this picture on the right here, here's normal cortex, and then there's this big step here, and we have that rest of the bone. So on a really obvious fracture and a big fracture that's quite malaligned, it's easy to see that disruption to the bony cortex. For some of them, they're a little bit more challenging, and the top tip is to get the patient to point with one finger where it's sore and look at the point of maximal tenderness and correlate clinically. So we're looking for discontinuity of the cortical line. We're looking for the bony displacement, looking for any sort of angulation that will help you understand how you need to tug on this to put it back into place. And we also want to look at any associated subperiosteal hematomas. So you can see on this example here, we have some hematoma developing here, and it's a little bit more hyperechoic up there as well. So normal bone is really easy. It's a straight white line. And we can see here, it's quite obvious that there's quite a big deformity in this bone. The other cheats method is, I think it's quite rare that people will fracture both sides in exactly the same place and in exactly the same way at the exact same time. So you always have a normal side to compare with, or something that should be more normal than the sore side. So this is an example of a 47-year-old male who fell out on an outstretched hand after tripping on a soccer ball he was playing with his son. So he had a swollen wrist, and it wasn't getting any better, and the whiskey wasn't helping. So what we did here was have a look at the left and right side, and in longitudinal, as you can see. Now this bit here is the normal joint space up near the wrist, but we can see here a clear discontinuity of the bone, or a step, which does not exist on this side where we have very smooth, bright white cortical line. So this is the same wrist. It's quite tricky. Like if you're looking at this x-ray, yeah, it's there, but it's not displaced terribly much on the x-ray. You know, maybe a little bit here, but it's much more obvious, I think, in this instance on the ultrasound exam. Here we've got some examples. On the left side, we have some examples of healing fractures versus an acute fracture on the right side. So you can see in an acute fracture, we've got really sharp ends of the bone. Whereas over time, as the callus forms, it starts to be, it's still irregular here, but it starts to smooth over. And as it's healing, it's not quite as sharp as what it is in that initial instance. Stress fractures are often really tricky to see. And I think sometimes, you know, if your patient comes in, they're splintered, and that splint and whatever bandage hasn't been taken off for the x-ray, you know, it can get lost in the artifact that's over the x-ray. And I'm looking at this image here thinking, I'm glad there's an arrow on it. But on the ultrasound, we can start to see just a little bit of irregularity. But on this, in this instance, that sort of periosteum fluid, and the sort of separation here, a little bit of the periosteum is what gives this away. We confirm that in the transverse, so we don't have that nice smooth cortical line. There's a little bit of elevation of the periosteum there. Ultrasound's great for rib fractures. They're quite common, and the sensitivity of detecting a rib fracture has been reported to be higher than that of plain radiography. Some studies found a sensitivity for ultrasound of more than 80%, and plain radiography around the 23% mark. So it can be tricky. Again, you've got these bony structures overlying the lungs, there's heart shadow, there's a lot in the road, and unless your radiography exposure is just right, or you've positioned them in just the right way to demonstrate that fracture, it can be quite tricky to pick up the small non-displaced fractures. Obviously, being able to diagnose a rib fracture can have a significant impact on how you clinically manage this patient, and on gauging the severity of the traumatic mechanism, the patient's disposition, and any analgesic requirements you might have. If we know that there is a significant number of rib fractures, perhaps we need to make sure that the patient is incentivized to do the spirometry and make sure they are practicing their breathing, which is likely going to be painful, so that they don't get other problems after as they're healing from the rib fractures. So there are some that sort of question what's the usefulness. You can't actually splint a rib, you can't plaster a rib, you can't do anything about it. The patient's just got to get better slowly. I know for my father fell off his motorbike, and when the doctor told him that he had fractured his rib, he was all of a sudden taking this much more seriously, and it provided a good excuse, if you like, for him to actually stay at home and take care of himself. So I'm sure for some patients, just understanding that, it's not all in my head, there's actually something broken in there, and I'm going to be in pain for another 6 weeks here. That can help them psychologically in that healing process, but also just perhaps that might be the final thing that tips them over to actually look after themselves a little bit better while they're recuperating. More than anything, I guess, if you're out in the WOPs and you're in an austere environment and don't have easy access to other imaging, being able to find these rib fractures and diagnose them and understand how severe is the rib fractures. Do we have a whole flail chest, or is it just one? Are they really quite displaced? Is there a big risk of one of these kind of poking into the lung and deflating it? It can help on how you discharge the patient and how the patient needs to look after themselves. Oops. So here's another example of a rib fracture with a bit more displacement than the last one. So essentially what you need to do here is, again, ask the patient to point with one finger. I always ask them for anything musculoskeletal, point with one finger, because otherwise you get this vague, somewhere here. So point with one finger and point your probe there. Put the probe directly over it. It usually correlates really nicely with where the injury is. Now here's an example of another patient who'd gone out and done the weekend sport and going for a ride on the biscuit behind the boat, and then complained of sore ribs and not much displacement here, but there's something certainly going on. And so this is the fractured rib. The next one up looks completely normal. There's other occasions, I know several times when I've been asked to perform an ultrasound exam looking at the supraspinatus, we'll get a form that comes in that says, query supraspinatus tear. And, the tendon's actually not too bad, but you do see a fracture. So this is a case of a 13-year-old girl who fell off her snowboard and she lands on her left shoulder. So she had x-rays done up on the mountain and they showed no fracture. 10 days later, she's still in quite a lot of pain. And so they thought, well, maybe she's torn her tendon, so referred her for imaging. So you can see in this example here, we have on the left, we have transverse views of the supraspinatus tendon, and that tendon looks lovely. And then here on the longitudinal view, again, the tendon looks intact and no real tendon damage. There's no bursitis. But on this longitudinal view, we have quite an irregular area near the on the greater tuberosity. And that's quite abnormal for a 13-year-old. And so as we go into this a bit deeper, we're scanning the supraspinatus in long at the attachment on the greater tuberosity. So we've seen this step in the bony surface. And then as we move more inferiorly, then it's really quite irregular over here. And you can see there's some bony callus formation, so that, you know, pop the colour on and it demonstrates a bit of colour, and there's some bony callus formation. And so as we, on some of the fancier machines, you can do this panoramic view and you can follow that sort of greater tuberosity down, and you can see that it's really quite significant area of disruption here. And when they re-x-rayed, it now looks quite different, and it's very definitely something's not right there. So it's interesting that, you know, that perhaps on the mountain that was quite undisplaced, and if the patient's gone away thinking, oh, I've just got a bit of a sore shoulder, I landed hard, and they haven't immobilized well, and now it's now it does look a little bit more displaced. But in any case, this this young girl was popped in a sling for 6 weeks and managed conservatively. Now, ultrasound is amazingly useful for sternal fractures, and there was a whole lot here that's saying way better than X-ray. If we take a lateral X-ray, you have to be really looking for the sternum, and the best view here, of course, and you can see the fracture just in here, the best view is that lateral X-ray, but you have to make sure as you're taking the X-ray that you give it enough herbs so that you get good penetration. And the exposure that you're using to get a good image of the sternum is quite different to the exposure that you're using to get a good image of the lungs. Now, the other thing that, as a radiographer, that we do is a left anterior oblique, right posterior oblique, so that we can pull the sternum and the manubrium here away from the spine, because if you're just doing a normal PA chest X-ray, the sternum and the manubrium are all superimposed by the spinal bones, and you don't see very much of anything. But even on this oblique image, it's really tricky to see, is there anything going on there in that sternum? So I think it was Chris Nixon and James Rippey did a study, and they discovered that ultrasound assessment of sternal fractures in their department, they had a median scan time of about 46 seconds, and the range was from 30 seconds up to 112 seconds in an audit they did of 20 scans in their department, and they found that it was quite good at picking up sternal fractures. So here's an example of a sternal fracture. Again, we're going to scan in the longitudinal scan plane, marker pointing to the patient's head, and we're just going to run the probe right down the middle. And perhaps you do a couple of passes and move your probe over a little bit. Sternal fractures almost always run transverse or obliquely across the sternum. So if we've got our probe in the longitudinal scan plane, we'll pick it up quite nicely. And you can see that discontinuity. Now, depending on whether it's just through the one cortical surface or whether it's gone through both cortical surfaces, how much displacement or angulation you might notice. But you have to be careful about calling the sternomanubrial angle or the xiphisternal junction as fractures. So again, this is about, can you point to where the sore spot is, and being mindful of where the joints are between the manubrium, the sternum, and the xiphisternum, so that you don't mistake those as fractures instead of joints. Pediatric skull fractures is another really useful place to use the ultrasound. We don't want to expose these babies to too much ionizing radiation, but not only that, if you've got a little baby, to be able to get a good CT of them, you need to sedate them most of the time. So by being able to do an ultrasound, you avoid sedation and ionization in the CT scanner. This is an example of a baby, 7-week-old, was dropped headfirst onto a hardwood floor by their 3-year-old brother. So The baby was crying straight away and had a fairly innocuous looking bruise in the right occiput. At 7 weeks of age, the skull is relatively thin. And as I said, doing a CT on a 7-week-old is sedation, it's ionizing radiation, and it's a bit of a palaver. So being able to just whack on a blob of gel and without putting pressure on, being able to just balance the probe on the head, you know, you can detect the the skull fracture quite easily. So again, the tip here is where is the bruise, and put your probe there and just extend your scan, you know, a little bit each way of where the bruise is or the maximal tenderness is, so that you can make sure you've covered the area. Now on this particular example, this is a suture line and this is a fracture. So you can see that it's very easy to confuse a suture line with a fracture. So how do you know which is which? Look at where the bruise is. But the other thing is you can always go to the textbook and remind yourself where those suture lines are. But also too, there's symmetry about those suture lines. So you can either go to the other side and then just follow it through to the frontal fontanelle and you know, determine whether this is a suture line or not. In this case, every time we put the probe over this area, the kid cried. So we started to go, well, perhaps that's something more than just a suture line, because they don't normally hurt. So hang on, here we go. So here's another example. A mother brought in her 3-month-old daughter to the emergency department. She was a bit irritable out of falling out of the car seat onto the concrete the night before. She didn't have any loss of consciousness or any vomiting. She was a bit fussy. And mum also noted swelling on the right side of her scalp. She'd been tolerating her feeds pretty well. You know, everything else sort of said that, you know, she's okay. But she had a fracture right here, and the CT reconstruction demonstrated that fracture. Again, big tip here is just use a massive big blob of gel so that you balance the probe on the gel without dispersing it too much. You're using that blob of gel as a standoff pad, essentially. Now, the other thing that you can occasionally pick up are bone tumors, and you know, there's disruption to the bony cortex, but they kind of look a little bit different to the acute fracture. Apart from that, the history is going to be different, but you can see here there's some soft tissue stuff. So this was a benign bone cyst, and you can see this sort of round structure and the x-ray for comparison here. And here is a couple of examples of malignant bone tumors. It's irregular in a different way. There's not that sharp angle, and there's also this sort of soft tissue that's not, it's not fluid, it's definitely soft tissue, and you know, it just doesn't look like it should. The other thing you can do here is just pop the color on and see if there's prominent blood flow, because a hematoma shouldn't really have blood flow, whereas some of these malignant tumors, you know, they usually have good blood supply to keep on growing. So then we move on to some hematoma blocks. You know, you've got this patient who comes in, you've x-rayed them, you've reduced the fracture, plastered up the arm, and then they go around for their post-alignment x-ray, and then it comes back and you think, yeah, that's still not great. You know, when it comes back, it's still looking a bit rubbish. And now you've got to go back and explain to the patient, well, actually, we either need to sedate you again or put on that Beers block again or whatever it is, but I'm going to have to cut off the plaster and start again. It's not, I wouldn't like to have to go and tell the patients that. So, you know, this is where ultrasound can really come into its own again. So it's quite clear where the deformity is. You can see where the fracture is. And, you know, anyone looking at this would go, well, why do I need ultrasound for this block? Blind Freddy could do that. Now, the hematoma block is just a technique to inject the local anesthetic into the hematoma between the bony fragments. Then you can manipulate it much more comfortably. And there's any number of studies that talk about, you know, self-reported pain scores that, you know, people felt that they were quite comfortable and it, you know, wasn't too bad considering all things. But, you know, in this case, yeah, probably you can do a blind hematoma block. But what if your patient looks like this? You know, it does become a little bit more tricky to understand, well, exactly where is the hematoma. The other problem with undisplaced fractures is that, you know, the hematoma might be much smaller and you have to be quite precise with your placement of the block. So if you've got an undisplaced fracture and not a really obvious bruise on the patient's skin, then it's going to be harder to find. Now, the advantage of a hematoma block is that you don't need procedural sedation. So it can be a one doctor show rather than, you know, if you have to sedate the patient, you need two doctors, one to monitor the airway and one to do the procedure. So, you know, this comes into its own again if you're out working in those smaller departments where you just don't have the staff. Now, the other pain control options, apart from the conscious sedation, is Beer's block, the regional nerve blocks, and of course, just a blind old hematoma block. The Beer's block, not everyone has the skills or equipment. Sedation requires a couple of doctors so that one can reduce and monitor the patient while the other one does the block. Regional nerve blocks are probably, you know, you need more ultrasound training to do that, and you need to be really quite practiced at doing them, and particularly for the arm up in the brachial plexus here, you're in tiger country a little bit because, you know, it's not too far away that you can stick the needle into the nerve or get an artery or a vein. So you need to really know what you're doing, and they're a heck of a lot more difficult to do than just a straight hematoma block. So, you know, the hematoma blocks blind on most people can work, but there are some patients, like we've just spoken about, that they're not suited to, and that using ultrasound to guide your approach will result in better anesthesia and pain relief for your patient. So my technique, or my recommended strategy here, is to do a scout scan first, and this is where you're going to identify your target. So you're going to find your hematoma, make sure you optimize your image so that your image is as good as it can be. You want to assess the surrounding structures to make sure you're not going to get something else by accident. Plan your approach. Make sure you're really conscious of where your needle's coming from, which side of the probe it's coming from. When we're assessing those surrounding structures, for the upper limb, most of the important neurovascular structures on the upper limb are contained on the volar soft tissue, which means the dorsal or lateral approach is better, whereas the lower limb, the important neurovascular structures are contained in the proximal anterior thigh or posterior in the leg. So that makes the lateral approach better for the proximal thigh, and the anterolateral approach for the mid-thigh distally. So we need to think about where are those surrounding structures that are going to prove problematic for us, and plan our approach. Are we going in plane, out of plane, and, you know, which side is the needle coming from? And depending on your patient, it's a good idea to measure the depth from the skin to the target so that you can get an appropriate length needle to be able to get your anesthetic into the target area. Now, a few tips again, and we covered some of these for the vascular access, but they're the same, and I just thought we'd chuck it in here as a reminder. The in-plane approach is probably the preferred approach here because you can see the needle all the way from the skin surface and target it quite specifically into the hematoma. Make sure you're comfortable. So get yourself set up and take the extra few minutes to do that. You don't want to hold your probe like a dead rat. Everything will slip over, and chances are you could be leaning too hard on the patient as well. So hold your probe quite low down and support your arms and forearms as much as you can on the bed around the patient, because that allows you to hold the probe quite lightly on the patient without, you know, putting any pressure on the tender limb. The in-plane approach, you have the needle visualized all the way from the skin surface. And so coming in at sort of 45 degrees is the sort of compromise between getting deep enough and being able to visualize your needle well. It's important to remember that when you're in that in-plane approach, the ultrasound beam is really quite thin, and it comes out the end to like about the thickness of a credit card, and you need to thread your needle right down the middle of the whole credit card to be able to see it. So, you know, here we've got some examples. If I'm smack bang in the middle of my probe, then I should have good reflection from my needle and reverberation artifact. But if I'm just off axis, now when I first did vascular access on the Phantoms so many years ago, I think the most surprising thing was just how thin the ultrasound beam was. I don't know that I ever really thought of it before then, but you can just be a little bit off axis and you will not see the needle at all. You might see tissue planes moving a little bit, but you won't see the needle. And so you get nothing. And if you are a little bit crooked, and I've exaggerated here to illustrate the effect, you will only see the needle where it intersects with the ultrasound beam. So that means you have to take that extra bit of time and make sure your needle is smack bang behind you and lined up with the long axis of the probe, because this tiny little bit of angulation here, by the time it gets to the other side, is way off course. And this is a really common error, this parallax error. You think you're behind, but you're not quite. And so then you have trouble visualizing your needle. Now, the other thing I did mention was in planning your approach, just be mindful which side is the probe marker on, which side is the screen marker on, and where am I expecting the needle to come in from? Because I've seen it happen many times in our prac sessions. You know, people are watching intently over here, but the needle has come in and gone all the way through. So you need to be mindful of which side are you expecting the needle to come in from. Now, here's an example of, thank you, Alan, of a ultrasound guided hematoma block. The needle coming in plane, and it comes back in a second.
Lost a bit of contact there.
Pardon?
Lost a bit of contact for a second.
Yeah. So you can see the needle coming in, and we're just injecting a bit of anesthetic up there, and you see the tissue
coming in now.
Disperse a bit.
And I'm just injecting now. I'm probably slightly away from the hematoma fracture. You can see I'm probably about, I don't know, about 2 millimeters away from my ideal spot. But, you know, volume solves a lot of things. so I just I'll make sure I give 15 mils rather than 10 mils. Like Suean said, it's not as easy to get the needle under the probe as you think it is. Plus, it's actually hard to even keep good contact. I thought it had plenty of gel on, but, you know, the thing is deformed, it's round. It's hard to actually keep it staying on the whole length of the probe. The other thing is, I will say, is it has a feature that I didn't use, which people can work out for themselves, which actually illuminates the needle and turns it a color. And actually, I regret I didn't use it because I wasn't quite aware of it or how to use it at the time. And I would have loved to test it out and see how it actually, whether it made it easier to visualize the needle. I suspect it would have, but unfortunately I didn't actually use that option.
The other technical thing that I'd say here, Alan, is just winding the gain down a little bit.
Yeah,
it actually your visualization.
It actually looks, you know, with these things, it actually is brighter than it actually appeared on the screen. But once you've translated it across to, you know, you've sent it to your computer and then whatever, it always just makes it look different. But it wasn't quite this bright in real life. And I took a good sort of 20 or 30 second clip actually just to satisfy myself that I was in the right spot and sort of slowly injecting at the same time. What was the other comment I was going to make about it? No, I can't think. That was my first one, by the way, so I don't think I did too badly. And it did work, so that, you know, that's always a nice for your first one. The other thing I was going to say was needle choice. I only really had a choice of a couple of needles in my department. One was like labeled as a needle block needle, but it's got this little stubby thing about 3/4 of the way up the needle, which stops you introducing it any further. I'm not sure if people are familiar with that type of needle. So I actually found by the time I got the tip to where I wanted to, that was right up against the skin, and I couldn't have advanced it anymore if I wanted to. And you've got to just keep mentally thinking, multiply by like roughly 50%, you know, your depth that you need to get to, because you need, you know, long enough needle. The other needle I had was basically a spinal needle, but a non-blunt spinal needle that was about 90 millimeters and about 20 gauge, which in retrospect I probably would have chosen, but it was a bit thinner gauge than the one I was using in that picture. And even that one, which was a bigger gauge, I suspect it was like 18 gauge or something. It's still not that easy to see.
Yeah, it's interesting you say about the needles there, Alan. I know Liz Prentice, who does a lot of stuff at the Children for Vascular Access, and she talks about having, you know, best practice for vascular access is making sure when the needle tip is in the middle of the vessel, you should still have 50% of the needle outside the skin, so that you're not, you know, as you say, right up to the hilt, getting to your target, so that it flicks out or it just doesn't quite get far enough in. So
yeah.
And that's part of that scalp scan procedure before you scrub everything up and get everything ready to actually go, is just planning your approach and going, well, what needle do I need? It's very easy to put on the calipers and sort of take a rough measurement and to figure out, well, maybe I need it a bit longer than I thought.
I should have noticed the distance on the side. I should have measured it, because when you look at the patient actually, so it was just an average sized patient, and you're sure it was a bit deformed, obviously, and a bit swollen, but I thought I had plenty of needle. I just thought I had plenty of needle, and it just goes to show you just got to measure, you know.
Yeah. And so these are the x-rays before and before. So then this video is after Alan has aligned it. At least that's what I was assuming, Alan. And so you can use the ultrasound to just check the alignment of the bony fragment. And
so I'm just sliding from distal to proximal. I'm over the distal radius, and there's the carpal bones coming in. And then I'm moving proximally back up the radius again. And you can see the little sort of gap there and irregularity. It's quite smooth now compared to before. So I was pretty happy with it at the time. But as I said in the chat, you know, it's great because you don't have to find a resus cubicle. And lately, we're just struggling to find a spare resus cubicle. The adult patient doesn't have to be fasted. So, you know, it has, and nursing staff, like you said, not only not a lot of doctors, but you don't need a lot of nurses either. So it's almost like a one senior doctor and a well-built intern resident sort of job to help you with the manipulation, and you're done.
The beauty about checking the alignment with the ultrasound before you put the plaster on is that then, you know, if it's not right, you can, while that block is still in place and without having to do everything all over again, you can then, you know, tug on it a bit more and make sure that the alignment's good, and as good as you think it can get before you put the plaster on. And so here was the x-ray after, which, you know, looks a whole lot better than what it did beforehand.
And if the radiologist's report was it was barely improved, I thought he was being a little bit hypercritical, especially with the ultrasound and the X-ray. But that's fine. Yeah, I was going, and as you say, even more important. I mean, I think it's done fairly routinely. I think for Colles fractures now that, you know, people ultrasound it. It's particularly before and after manipulation, but also because, you know, even more so because it's still mostly procedural sedation's being done. And the last thing you want to do is let the patient wake up and you haven't reduced it properly. So, so I think at least with a nerve block, you know, you've got a bit of time to have a second chance, you know.
Yeah.
Oh, sorry, I should say a hematoma block in this case. But, you know, the same principle applies to nerve blocks, doesn't it? Basically, everything we're saying we could do for a nerve block, but I'm just not skilled in nerve blocks yet. And I thought an ultrasound-guided hematoma block was an easier one to learn at my stage.
Yeah, absolutely. Certainly the, you know, we teach the brachial plexus to the anaesthetists. And yeah, it does take a little while for them to be able to just recognize the anatomy, but there's just so much more tiger country up there. You've got vessels that are close to the heart, you've got the lungs, lots more can go wrong.
Is anyone else on the call doing any ultrasound guided hematoma blocks or nerve blocks for upper limb fractures at the moment?
Yeah, and I was going to make a quick comment. I have to admit, coming from the United States, I never trained in doing Beers blocks. It was all hematoma blocks, and this was in the mid-1990s, we did the all blind technique. And about 10 years ago, there was a tricky one where I knew the bone was really impacted. And I thought it was going to be really tricky to get my needle into the hematoma using a blind technique. And I thought I was really clever using ultrasound guided technique and thought I'd write it up. And so, of course, I go to the literature, and sure enough, it's been reported numerous times. So I lost that opportunity. But one thing I will say is, I'll make one quick comment, is you really try to get into the hematoma, because the times where it doesn't work is when you're not in the hematoma. You really want to have that beautiful flash back of blood and a nice, easy flow of anesthetic going in. In my opinion, you can't really cheat this too much, because it just won't work unless you actually get into the hematoma. I've actually tried hematoma blocks for the ankle fracture dislocations. It works beautifully. So it's amazing. You have a person who normally would go to the resus room and take up all kinds of resources. We're doing these in our fast track area. And the last area I tried, and I don't recommend this, is trying to do hematoma blocks of neck of femur fractures. There's not much vascularity to the neck, and there's not a big hematoma to actually get into. And I thought it'd be clever and try it. It turns out it doesn't really work. And it's very hard to guide a long spinal needle with a curvilinear probe almost parallel to the face of the probe. It just doesn't work. So don't try that.
I was actually quite surprised in looking up and preparing for this talk today. I thought Beers blocks were pretty run of the mill, and perhaps they were at Cairns Base Hospital when I remember seeing them quite a lot as a radiographer. But I was quite surprised to find that, you know, not every hospital even has the equipment to do it, let alone the trained staff to do it.
We used to do heaps of them in the hospital in Melbourne that I trained in. And yeah, we did heaps of them. We did a lot of them in Ireland in the early 2000s when I was over there. But I think similar to what Brian was saying, in the UK back in the late 90s when I was there as a registrar, they just did blind hematoma blocks. But I never tried those, but I'd always heard that the success rate wasn't fantastic. Like you'd have like a 65, 70% success rate, whereas I think the literature for the ultrasound guided hematoma blocks is saying it's in the 90s. And as Brian said, I looked it up recently, there's some good literature about using the hematoma blocks at the ankle. So that's certainly one I'm interested in trying out next time I get the opportunity in the right patient.
Look, you can always have a go with the hematoma block, and you'll know if it doesn't work, and then you can move on to a plan B. You know, so I don't have a problem with that. There is a lot of regional variation as far as which areas do procedural sedation or Beers blocks or even hematoma blocks. Where I'm working now, I'm in the minority. Some people think I'm barbaric for doing hematoma blocks, but I think once they see how efficient and quick and less resource intensive they are, I think you see the converted.
I had a Smith fracture patient, which was probably worse than this Colles fracture patient on the weekend. And I was thinking, I'll be smart. I'll do a hematoma block. And I put the probe on, and then I saw this wriggly radial artery that was just going to be hard to get around. And then obviously the depth is more because you're coming from the volar surface where there's more structures and tissue. I just thought, you know, this is going to be more challenging. I'm going to bail. So I bailed out and waited, and eventually got around to doing procedural sedation on it.
It's interesting. Today, I think EMJ has published an article where they said hematoma blocks didn't result in any statistically significant better outcomes for the patient. But I thought, even if it was equivalent, if you're missing a radiation dose and not risking a second sedation or a second procedure, then it's not worse. So it was interesting because I was just before I came on the call, I was having a look at that. But did anyone else have any questions? Because it's over to you now for any other questions or comments.
I've got a quick question for you, Suean. You use the term that you're a quote unquote gel snob. I like that. That's pretty cool.
I'm a gel snob, absolutely.
What do you mean? Is there more viscous gel that you can purchase? I had no idea.
Yeah, no. There are, so, you know, some of the radiology companies have gel that you use on most people that just completely runs off the patient because it's really thin. And you don't need much and it'll hang around, but it just slips everywhere. And then there's the really thick viscous stuff. So the Aquasonic is quite thick, and there's a couple of Australian sonographers actually have created their own recipe, and it's as good as the Aquasonic stuff and significantly cheaper. But it's quite thick and it sits and it just doesn't slide off as much. And so you can really, load it up and it'll sit there and you can kind of have a big blob of it and balance your probe on the gel. Whereas some of the stuff that's quite thin, it spreads easy. If you're doing an abdomen exam, it's great because it spreads really easy. But, it slides everywhere and gets in your clothes. And anyway, I reckon 25 years in this game, I've earned the right to be a gel snob. Do you know what brand you have at your place, Brian?
I've got whatever's in the drawer.
Yeah.
To be honest,
there was one that I saw at the conference recently, and it came in different packaging. So, and it's fully recyclable packaging. But the plastic gel bottles, you've always got an inch down the bottom that you just cannot get out. And if it's a single-use gel bottle, you're throwing that out all the time, and that plastic is not that recyclable. So there was the this I think it's called EcoView, and it's in like a squeezy tube pack, like I don't know, even from my first child to the second child. The first child had the tins of custard, and the second one was in these squeezy tube packs, and you just shove it in and squeeze it in their mouth. And it's those kind of squeezy packs that mean you can, like the toothpaste, you can squeeze it all up to the top and truly empty it. But then when you've emptied it, it is a recyclable packet as well. I think if I'm going to be a gel snob about it, it's a bit thin, but it's, it's not bad. It smells nice too.
The one thing I'm doing is, because we don't have the advantage of single-use ones for, those hot query COVID, query whatever infectious patients that you're supposed to be using single-use. And I don't want to waste the bottle. I mean, obviously, you could just leave the bottle if you've got a hot area in there for the next hot patient. But we have a structure where we've got sometimes an isolated cubicle that's a hot cubicle, but in a cold area. But what I did, I read that what people were doing was they were using syringes and sucking out the bottle, but it gets really messy. I tried that quite a few times. It's frustrating getting it out of the bottle. You got to wipe it off the syringe. It's really messy. So then I thought, why don't I just use a urine container? So I just glug, the urine container full of gel, and that's much quicker. And I just take the urine container in with me, and I just keep dipping it, like a sushi roll in some soy sauce. I just keep dipping it in there each time I use it. I usually have enough in the MSU container, and then and then I haven't wasted the whole bottle. I don't have to clean the bottle or whatever else you're going to do. So that's
depends what the top is. And again, I'm a bit of a snob about what's the best lid on these gel bottles, because some of them you really have to squeeze hard to get it out. And I've suffered from, having elbow injuries just from too much squeezing of the gel bottles. But so I'm a bit fussy about my gel bottles. But if it's got the right sort of lid on it, you can just use the bigger 20 ml syringe. And if you do it, you can get much more cleaner at preparing those syringes, Alan.
Alan, I'm interested to hear what your dog has to say.
I was just saying, you got a new fan for Coaching Corner.
Anyway, so I said, if no one's got any other questions, and we can certainly chat offline in a moment. But again, I'm just going to say thanks to Philips for all their support during the year. And it has been a challenging year. We were 229 days we were closed. So it's super exciting to be back doing what we love and doing face-to-face teaching again. But their support during the lockdown period has been very much appreciated, and in bringing these sessions to you as well. Now, our next Coaching Corner will be the first Thursday of the month in February, which is the 4th of February, I think. And I'm going to be looking for topics. So send me a tweet or send me an email, whatever, so that we've got some topics lined up for the next Coaching Corner. So yeah, other than that, I think it's time to wish everyone, because we're in December, that seems like it's come around quite quick in the end, but otherwise it's Merry Christmas. Would you believe it?